In the session?
Yes, ma. We'll begin. Thank
Yes,
you.
Good evening, ma'am.
Good evening. Nice seeing you.
Thank you. I'm presenting today a case of an elderly 65-year-old male, Mr. XYZ, who is a farmer by occupation hailing from Doddaballapura. The informant was himself and his wife, and the information was reliable. He presented with the chief complaints of involuntary movements of both the upper limb since 2 years, and difficulty in walking since 1 year, and history of fall 1 month ago. The patient was apparently all right, performing his routine daily activities 2 years ago, when initially noticed involuntary movements of the upper limb. It started such that it initially started in the left upper limb. It was present at rest and disappeared on performing activities and during sleep. The attenders also noticed that the involuntary movements increased on speaking or watching television. It progressed such that the involuntary movement involved the right upper limb after 6 months with similar complaints. There was history of associated difficulty in performing daily activities like eating, mixing food, buttoning or unbuttoning shirts, such that the patient took longer to perform these activities but was able to perform them as before, but took a longer time to perform the same. There is also a history of difficulty in walking since 1 year, such that the patient and the attenders have noticed there is a difficulty in starting to walk, after which the patient took multiple small steps during walking and slowed down at the end of walking, and also had slowing when turning from side to side. The patient attenders also noticed that there was a loss of arm swing while walking, and there are multiple steps while walking. There is no history of stiffness of limb, thinning of limbs, difficulty of gripping slippers or holding objects. There is associated change in the handwriting noticed by the attender, such that they noticed that the size of the letters appeared smaller throughout the handwriting compared to previous. The patient also sustained a fall 1 month ago, during which the patient was conscious and he slipped over a wet floor, following which he had a left hip fracture, and patient is being conservatively managed for the same, and does not want any surgery to be performed. So currently he is immobilized in view of the same. There is no history of increased salivation, loss of smell or constipation. There is no history of diplopia, palpitations or movements of the limbs during the sleep. There is no history of change in mood, irritability, lethargy. No history of any cranial nerve involvement. There is no other sensory symptoms or motor symptoms. There is no history of swaying while walking or repeated falls, recurrent falls. No history of other system involvement. There is no history of increased frequency of micturition, urgency, volume, or reduced sensation or fullness with respect to the bladder involvement. Personal history is a predominantly consumes a vegetarian diet. His appetite has been reduced. The bowel and bladder habits are regular. Sleep, he says it is reduced and has difficulty in falling asleep. However, he has 8 hours of sleep as compared to previously, and there is no change in the duration of sleep. However, there is reduction in the initiating the sleep. No history of risk factors like consumption of smoking or ethanol consumption or any high risk behavior. Family history, there are similar complaints in the father, which began at the age of 70, for which the patient's father also was taking some medications, however was not adherent to the same. Drug history, there is no history of any chronic PPI use, to mainly think of like drug-induced involuntary movements.
PPI means what, ma?
Proton pump inhibitors.
Okay. Antipsychotics. If you want to tell about drugs, antipsychotics, anti-vertigo, this is sinaricin, flunarizin, and psychiatric medications. Then this ganja, MPTP.
MPTP, okay.
So those things are significant.
Yes.
So you summarize and we'll discuss. Okay.
Yes, I'd like to think of an elderly male with no comorbidities, presented asymmetrical onset, resting tremors with bradykinesia, and a positive family history of similar complaints with no autonomic features, cranial nerve or sensory or cerebellar involvement. I'd like to think of a possible diagnosis of a Parkinson's disease owing to the asymmetric onset and elderly age of presentation.
Okay. So we will start with the first symptom of involuntary movements, which started in one upper limb and then involve the opposite upper limb. No, left upper limb,
Yes.
then the right upper limb.
Yes, ma'am.
So whenever there is an involuntary movement,
Yes, ma'am.
we have to describe under certain headings. No?
Okay.
So that we will know what it is. Involuntary movements are broadly classified into what? One is psychogenic, second is organic. No?
Organic, yes.
Psychogenic involuntary movements are there a large number, and organic. Under organic, you have got hyperkinetic and hypokinetic.
Yes,
Under hyperkinetic, you have got tremor, myoclonus, chorea, athetosis, myoclonus, chorea, and tremor or hyperkinetic, hemibalismus. Whereas hypokinetic is dystonia, athetosis, and Parkinsonian bradykinesia. So this will be the broad classification of psychogenic. How do we think? One, as if it is seen commonly in young females in the presence of others, and it is not fitting into one patterned involuntary movement, not stereotyped. Even though it may be the same according to patient, you see two videos, it will not be superimposable. And normally an organic movement disorder worsens when you distract the patient. Because patient has to focus on the involuntary movement so that he is able to maintain himself in balance. But when you distract the patient, if it worsens, it is organic. When you distract the patient, if it becomes better, it is psychogenic.
Right.
So these are some points. So when you describe an involuntary movement, we have to discuss rate, range, rhythm, direction, amplitude, any precipitating factor, any relieving factor, what happens during sleep, and what happens during emotions. So some of these things you told very well. So rate, grossly only, because in the EMG machine, we can find out the rate by hooking into an EMG machine and frequency analysis. But at the bedside, grossly we tell. If the rate is more than 8 hertz, you call it as a fast movement. And if it is less than 8 hertz, we call it as a slow movement. So fine, fast movements are usually physiological. Physiological tremors, not at all uncommon. Just before we go for exam or when we are hypoglycemic, we tremble standing in front of someone asking frightening questions, no? They are all fine, fast movements. So low frequency involuntary movements are always abnormal. High frequency movements may be physiological, beta agonist, no? Or thyrotoxicosis, those conditions. The pathogenesis of physiological tremor, we call it as ballistocardiographic effect. You see, when you are under stress, what happens? Adrenaline will be released. And the adrenaline will have an inotropic and chronotropic effect on the heart. So it will increase the force of contraction and the frequency of contraction of the heart. That will put the body into a vibratory mode. That is called ballistocardiographic effect. Normally also we are having a subclinical tremor which is not visibly seen. It is not visible. So body is constantly in a vibratory mode because of the cardiac action. But it is not perceptible. When adrenaline is released, it becomes perceptible. So that becomes more obvious. So it is called ballistocardiographic effect. Physiological tremor, pathomechanism. One is ballistocardiographic effect. Second is, you have got something called critical fusion frequency. In physiology, we would have learned that when you want to carry out a movement to write a letter A, we have to put some muscles as agonist, some as antagonist, some as synergist, some as fixator, so that your beautiful handwriting is reproduced. So that is called critical fusion frequency. But when you are in a fight or flight mode, so when you are threatened, you are in a fight or flight mode, that time the grace of the movement is not important, but you run. So the critical fusion frequency, the number of units recruited into agonist, antagonist, synergist will be changed. So the activity becomes crude but faster. So that becomes more manifest. So second is altered critical fusion frequency. One is the ballistocardiographic effect. Second, because of the gravity of the situation to fight or flight and not create a beautiful action, there is a lowered critical fusion frequency and the movement becomes crude. Faster maintenance becomes crude. So it will produce an involuntary movement. And then you know that there is a direct effect of adrenaline-induced changes in the metabolism. So that also produces trembling in the limbs. So that is physiological tremor. So rate is important to know whether it is physiological or pathological. Most of the physiological movements are very fast and fine, whereas pathological movements are slow and coarse. So that is rate. So in our patient, we have to find out what is the gross rate when we examine the patient. Next is the range. Range is whether it is involving one joint or it is involving more than two joints. So if it is focal, segmental, generalized. So we give a term to the movement as focal, segmental or generalized by the range. If the movement is involving only one joint, it is a focal movement. If it is involving two or more joints, it is a segmental movement. If it is involving the midline structures, including the trunk, it is a generalized one. So you want to know the range, whether it is focal, whether it is segmental, or whether it is generalized. So first thing you will know is the rate of the movement. Second is the range. Range, whether it is focal, segmental, or generalized. The term generalized is used when the trunk is involved. Then you have to know the rhythm. So it is rhythmic or arrhythmic. What do you understand by rhythmic is when an upstroke has happened, the downstroke you can predict. Supposing you have got a predictable downstroke, that is a rhythm. My patient's arm moved 5 degrees up. So next you can tell this arm is going to move 5 degrees down. That means it is rhythmic. Supposing you have 5 degree up, then 7 degree down, and then 2 movements up and 1 movement down. That is arrhythmic. So you have got arrhythmic tremors and you have got rhythmic tremors. You see, they originate from different locations. Typically, we call arrhythmic pseudo tremor. You might have heard of arrhythmic pseudo because rhythm tremor is rhythmic. So when it is arrhythmic, you call it as a pseudo tremor. When we call arrhythmic is when you do not have a predictable next movement. If your next movement is predictable, it is rhythmic. If you cannot predict, it is arrhythmic. Pseudo tremors typically happen in peripheral neuropathy. Metabolic disorders, anterior horn cell disease. So mini polymyoclonus, which happens in uremia, hepatic encephalopathy, or you have got pseudo trauma due to peripheral neuropathy, or it is happening in anterior horn cell disease, where the rewiring or the repair, when a peripheral nerve is destroyed, some of the alive fibers try to repair, but they repair the muscles which supply, if the nerve may belong to a muscle supplied by the agonist. And so the same nerve might repair the antagonist. So agonist and antagonist will contract together. The repair takes place by a viable nerve. The viable nerve may be the primary innervator of the agonist. And now when it repairs the antagonist, it goes to supply that also. So the normal pattern is lost. So you get a arrhythmic tremor. Many polymyoclonus is metabolic. It is a shock-like. It will have a shock-like quality. Unlike the arrhythmic pseudo tremor of peripheral neuropathy, which does not have a shock-like quality, metabolic pseudo tremors have a shock-like quality. So that is why you have to know whether it is rhythmic or arrhythmic. So first is the rate, second is the range, third is the rhythm. So rate, range, rhythm. Next is the direction. What is the direction in which the involuntary movement is taking place? Is it a pill rolling movement? Or is it a to and fro movement? Is it in the horizontal plane? Is it in the vertical plane? Or it is in multiplanar? So you classically you have got the rubral tremor, horizontal action tremor. So it is very, very specific. But all action tremors can be rubral, but the severe specificity is there when it is horizontal. So like this. So you want to describe what is the plane? Is it vertical plane? Is it multiplanar? Or is it horizontal? Or is it out of phase like the pill rolling and drum beating movements? So all that is the direction. So rate, range, rhythm, direction. Next is the amplitude. Very low amplitude means 2 to 3 degree up, 2 to 3 degree down. That is the amplitude. Very fine movements are low amplitude. I told fast frequency, low amplitude movements are physiological, whereas pathological movements are high amplitude. So they are more than 5 degree oscillations. So high amplitude movements are always pathological. So rate, range, rhythm, direction, amplitude. Then precipitating factor. In your patient, you told that his movement becomes aggravated by emotions or when he is in the presence of others. Something like that you told, I think, no?
Yes, ma'am.
So that means there is a precipitating factor can be an action. Precipitating factor can be a posture. Precipitating factor can be sleep. So nocturnal movement disorders are there. Or precipitating movement may be a movement, task specific. Some particular task might produce a movement, no? Or the movement may be aggravated by emotional situation. So in this patient, it apparently appeared that when others are watching, his movement is increasing. So that means, so what aggravates the movement? Sometimes alcohol will reduce. Some involuntary movements are reduced by alcohol. You know the diagnosis. It is a benign familial tremor, no?
Yes.
So like that. So is there any precipitating factor, any relieving factor? So those precipitating factors and relieving factors will help us to, one, plan treatment. Second, make a diagnosis. As I told, alcohol release means, you know, it's a benign familial tremor. You're not going to use alcohol to treat that, but it helps us to understand what it is. Then emotions aggravating means it's a very, very vital clue. So you have got, when you are emotional, you have got 3 dopaminergic systems. So emotion induced aggravation, that is in presence of others. When somebody is asking questions, somebody is watching you, the involuntary movement is becoming worse. That means emotional circuit, limbic circuits are involved in the aggravation of the involuntary movement. That is what it indicates. So what happens, then you know that limbic, you have got 3 dopaminergic systems. So emotion induced aggravation is a very important clue. You have got 3 dopaminergic systems. One is the striatonigral dopaminergic system. Second is the mesolimbic dopaminergic system. Third is the tuberoinfundibular. The tuberoinfundibular belongs to the endocrine system. So that we are not going to take. You have got mesolimbic and striatonigral. Striatonigral and mesolimbic are counter-regulatory. So when you are emotional, you should not become erratic and slip and fall. So the mesolimbic will modulate all the movements. So mesolimbic and striatonigral have a reciprocal modulatory effect. So supposing you have a patient who is having a striatonigral dysfunction, like what happens in classical idiopathic Parkinsonism. Then what happens? The striatonigral is unable to modulate the mesolimbic because it has become weak. So mesolimbic takes the upper hand. So the modulatory influence of the mesolimbic on the striatonigral is increased. So striatonigral is disproportionately suppressed. That results in amplification of extrapyramidal involuntary movements. So when you have an involuntary movement, which is very much becoming obvious, well, that indicates there is an imbalance between the striatonigral and the mesolimbic dopaminergic system. In this patient, the mesolimbic is okay, the striatonigral is weak, so that is aggravating the involuntary movement whenever the patient is emotional. That is a emotions aggravator. Of course, emotions, as I told, you can amplify any involuntary movement by the ballistocardiographic effect, by putting the adrenergic drive into the involuntary movement. But classical aggravation is seen in extrapyramidal involuntary movements because of the modulatory influence of mesolimbic and striatonigral going in favor of mesolimbic dopaminergic system. So that is, so what are the relieving factors? What are all the precipitating factors? Relieving factors generally sleep. Most of the involuntary movements get relieved by sleep. Second, some of the involuntary movements get relieved by waking up. So that we call it a sleep benefit. When you sleep and wake up, your involuntary movements are much less because the dopamine stores have been restored. That we call it as a sleep benefit. Then some of the involuntary movements, dyskinesias, patient will have a specific point. He will hold, if you have an ocular blepharospasm, patient will put some hand on the outer canthus and the eye will remain open. I have seen some patient who is putting finger into the gingival pouch to control the oromandibular dyskinesias. So specific triggers and specific relieving points that help us to understand what kind of movement it is. So whether it is a sleep or wake up, sleep induced wake up benefit, or the sleep is abolishing the involuntary movement, or sleep is making the involuntary movement persist. What happens with music? What happens during seeing visual cues? For example, we tell that a person with extrapyramidal movement can climb much better than walk. Why he climbs much better? Because you have got the steps and each step points out as a stripe. It becomes a visual cue. That is why when we are rehabilitating these patients, we tell them when he is walking, draw dark lines in the floor. So you have got a sensory motor modulation. That is the mechanism of these trigger points also. Patient will put some finger somewhere and reduce the movement because sensory component is increased and the influence of sensory system on the motor system is enhanced by specific points. That only the visual cue also. So the patient says climbing up is easier than walking in the level ground. He is seeing the tips of the steps which become the contrast, visual contrast. So any specific aggravating factor, any specific relieving factor, relationship to drugs if the person has taken anything. So that is one. Then what happens during emotion, what happens during sleep, or any other unique features. Some of the patients may have auditory startle, tactile, stimulus sensitive, specific task. So the unique features are any task, any stimulus producing any alteration. So this much phenomena you have to describe in an involuntary movement. So apparently it appears that your patient has got a distal movement, asymmetrical, probably coarse, probably low frequency, probably it is focal, because we didn't get a history that it is involving the forearm, it is only the hand. So it could be focal. So if both hands, you call it as multifocal. So apparently your patient has got a distal, multifocal involuntary movements which is aggravated by emotion, and it is probably low frequency and coarse.
Yes.
So that looks like a slow tremor. So you got physiological tremors which are fast tremors. So slow tremors are pathological. So apparently from whatever history we got, it is distal, it is asymmetrical, it is aggravated by emotion, probably it is high amplitude, low frequency. And is it present during sleep or not?
Absent during sleep.
So it is abolished during sleep, or sometimes when you come into contact with the surface. So, and you told that it specifically improves when the patient is doing any action.
Yes.
So it is a rest tremor. So you saw that when he is eating or doing something, the movement is reducing. So it is a resting tremor, multifocal, distal, pathological. So which part of the neuroaxis you will want to, if it is bilateral and symmetrical, you have got a group of disorders. If it is multifocal, you have got group of situations. So where if it is bilateral, symmetrical, you will put a, you can have physiological tremor, thyrotoxic tremors, metabolic tremors, drug-induced tremors, no? All are delirium tremors. They are all bilateral and symmetrical. When it is asymmetrical, it is always due to a multifocal neurodegenerative process. So now we think it's a resting tremor because you said that during action this is disappearing. And whether it is pathological or physiological, one point is asymmetry. So when it is symmetrical, you have got systemic causes, drugs, as well as essential tremors when endocrine disorders. But when it is asymmetrical, it is always multifocal in the neuraxis. Then which part of the neuraxis you would like to put?
Think of the basal ganglia because it controls the extrapyramidal system.
Basal ganglia, agreed. Which part of the basal ganglia if you want to?
Think of substantia nigra here.
So now we are thinking it is tremor. So substantia nigra is of course in the Parkinsonian etiopathology. So here you can say that my patient's problem started in the upper limbs. So probably it is substantia nigra, you are correct. Because you see the homunculus. You know the homunculus of the human body in the substantia nigra. The upper limbs, it is like this. So the hands are towards the medial side.
Okay.
So it starts in the medial most part of the substantia nigra is the one which degenerates. That is why idiopathic Parkinsonism is usually upper limb onset. Because the upper limb in the substantia nigra is towards the center and towards the central canal. It is that area which degenerates. Whereas you get classical lower body Parkinsonism in vascular. Vascular Parkinsonism starts in the lower body. They will have the frontal lobe, NPH, frontal lobe tumors, no? Or vascular Parkinsonism, Binswanger's. They starts in the lower limb because it is the frontal subcortical white matter which undergoes degeneration there, and where the leg fibers are in the subcortex. In the frontal subcortex, the leg is closer. Paracentral, that white matter leukouriasis, where you see the leukouriasis. So it is the leg fiber. That is why vascular Parkinsonism is lower body, whereas degenerative Parkinsonism is upper body because of the homunculus. Substantia nigra, the upper limbs are more closer to the center and it is the medial most part which degenerates. So it starts in the upper body. Whereas lower body is because of the leukouriosis which starts in the frontal subcortex. So it is the lower body. So one agreed because it is upper limb and it is asymmetrical and the homunculus, so you thought it is Parkinsonism. So this tremor comes under hyperkinetic.
Yes.
So when you have decided it is a tremor, if you are asked where are you going to, of course we know extrapyramidal, it's a very broad term. Yes. So when you said upper limb, I can say probably medial substantia nigra. But when you have decided the movement is tremor, we can either say that your patient has got an involvement of the tremor loop. Let us say it's a tremor, but I have not characterized the tremor. I have to examine the patient. So I put the movement in the tremor loop. You can say that my patient's involuntary movement is in the tremor loop. Like that you can tell. Or you can say it is hyperkinetic. No? You have got direct pathway. You have got indirect pathway. You have got hyperdirect pathway. You have got nigrostriatal pathway and substantia nigra to pedunculo-pondine oscillator complex. These are the 5 major pathways in the basal ganglia. One is the direct pathway. Second is the indirect pathway. Third is the hyperdirect pathway. And fourth is the nigrostriatal striatonigral. And fifth is the substantia nigra to pedunculo-pondine oscillator complex. 5 major loops. Direct pathway is cortico, striato, pallido, thalamo, cortical. Cortico, striato, pallido, thalamo, cortical loop.
Yes.
In this, the globus pallidus interna. No?
Internal.
So cortico, striato, pallido, thalamo, cortical loop is called as the direct pathway. Direct pathway, when it is sick, it produces hypokinetic movement disorders. So bradykinesia, rigidity, slowness, no? Whereas indirect pathways, cortico, striato, pallido, there that pallidum is globus pallidus externa. Subthalamo, pallido, thalamocortical. So you add globus pallidus externa and subthalamic nucleus before the, after the striato. That is indirect pathway. So cortico, striato, pallido, subthalamo, pallido, thalamocortical. So you can say maybe my patient has got a problem in the indirect pathway. So indirect pathway will produce increased movements. Next is the hyperdirect, that is cortico, subthalamo, cortical. That is the third loop. Cortico, subthalamo, cortical is the hyperdirect pathway. Here you get hemibalismus. And the third is the nigrostriatal, striatonigral, you get the classical Parkinsonism. Then you have got the substantia nigra to pedunculopontine oscillator complex. So this loop gets involved typically in PSP. Substantia nigra to pedunculopontine oscillator complex, which is in the pons, lower pons. Pedunculopontine complex is in the lower pons, substantia nigra is in the midbrain. So usually this complex degenerates is called as the pacemaker of the movement circuit. So when the pedunculopontine oscillator complex is degenerating, patient starts as false. So when you examine, you might not find anything because it is only the PPN circuit that is degenerating. Patient will fall, and mostly these patients will be diagnosed as having osteoarthritis. Any old person will have some osteoarthritis because nothing else is visible at that time. You may not be careful enough to examine the eye. No? Somebody will replace the joints. I have seen that many times, and they are not improving. They are continuing to fall, and then the classical symptoms of PSP will emerge. So you can either say that my patient has got a problem in the extrapyramidal system, very good, and in the extrapyramidal system, is it in the tremor loop or in the indirect pathway? Like that you can tell. No? Tremor loop means olivo, dendato, rubro, thalamo, cortical. So whole of this loop will produce tremors only. Olivo, dendato, rubro, thalamo, cortical. That is called tremor loop. So many circuits are there in the brain. You know that the important circuits we take based on our case. As you know, if you take the olive is forming part of the Gillian-Mollares triangle. So when the olive is involved, you will get a palatal myoclonus. Yes, palatal myoclonus or palatal tremor. So olivo. Next is the dendate. Dendate is in the cerebellum. Then you will get an intention tremor. Next is the rubro. Olivo, dendato, rubro. Rubro is in the midbrain. You get a horizontal action tremor. That is a red nucleus. Thalamus. Thalamus has got a ventral intermediolateral nucleus. That is called the tremorogenic nucleus. It produces a rhythmic tremor which can be looking like essential tremor. Not like a resting tremor, not like the classical resting tremor. So you can get olivary palatal tremor, dendate intention tremor, red nucleus horizontal action tremor, thalamus you get a tremor which resembles essential tremor, and cortex you get a dysmetric tremor. Cortex is you have got a command loop and a correcting loop. So you are telling patient you take your hand and touch my finger. So you are given the command. And the command loop should be correctly matching the desired movement with the range and the time. So if there is any mistake, there will be overshoot or undershoot. So that is, then overshoot will happen, then the correcting loop comes and corrects. When it is correcting again because of the error in the calculation, it is undershoot. That is called dysmetric tremor. The target is there, you either overshoot or you undershoot. That is typical of cortex. So olivo, dendato, rubro, thalamo, cortical loop, you have got all this, and in between the red nucleus and the dendate nucleus is the exit point of the superior cerebellar peduncle. So in the limb of the superior cerebellar peduncle, if you have a lesion, which is typically seen in Wilson's disease, multiple sclerosis, no? You get the wing beating tremor. Wing beating tremor, that is in between the dendate nucleus and the red nucleus. You tell the person to keep the hand in abduction. So like the wings of a bird, it will, or you keep it like that, no? So it will be a wing beating tremor in between the dendate nucleus and the red nucleus. So that is tremor loop. So you can either put the lesion in the tremor loop and try to explain based on that. If you are not able to put it in this patient, it looks like a resting tremor. So you can take the indirect pathway.
Okay.
So indirect pathway. So you can say that my patient's illness probably started in the indirect pathway close to the substantia nigra. Corticostriatopallido-thalamo, corticostriatopallido subthalamo pallidothalamo cortical pathway. So that it more fits into the indirect pathway. So my patient's degeneration started in the indirect pathway. That is how you localize. Extrapyramidal system agreed and indirect pathway. So that is how you localize the first symptom. Next symptom, you told that he had a problem in walking. No?
Walking.
So to describe that walking, I thought you told that patient had starting difficulty.
Yes, ma'am.
So what are the difficulties you can have in starting?
One is the mental schema. If it is altered, then the patient may have difficulty in walking. Then it may be a motor weakness that the patient is not able to. Or the patient may have a sensory involvement that he is not able to feel the ground and then he is not able to walk. One may be psychogenic, that he doesn't want to walk.
Okay. So if the person has got a gait problem, which is mainly in the initiation, most important thing you have to think about is apraxia.
Apraxia.
Gait apraxia.
Gait apraxia.
You should ask, then only they will tell us. So you can have gait apraxia, which is, I forget about this case. Each symptom we are analyzing separately. I know that this case is idiopathic pediasia typically told, but we will discuss each symptom. So starting hesitation means you have to look for apraxia. So typically apraxia is patient feels that his feet is glued to the floor. So some of the patients tell that it otherwise also called a magnetic gait, because the patients tell that the earth's magnet is pulling my feet. I don't know what is happening, doctor. The earth's magnet is pulling my feet, so I'm not able to lift. Somebody help me, lift my leg and put it forward, then I will move forward. So gait apraxia, patient feels glued to the floor. He is unable to lift at all. So he will be making repeated movements with the trunk and the upper body. And if someone helps him by initiating, then he moves forward fast. That is typical gait apraxia. That is very classically seen in frontal lobe disorders, and classically it is NPH. No? NPH. So very important. Initiation defect means you have to see whether it is a gait apraxia. Next, if the person had been treated with some drugs and everything, is he having a freezing? So when you are slightly turning from one direction to another and you are trying to move forward, you become like a block. It is not necessarily the leg. The whole body becomes frozen like a block. That usually happens in patients with Parkinsonism who have been probably started with some dopaminergic drugs, and they go into freezing as a part of the disease or as part of treatment. So that may be freezing. So second thing, is it only the leg which is glued to the floor and looks like a magnet is pulling? It may be an apraxia. Is the patient experiencing freezing? Next, you said typically your patient has got a start hesitation. So he is making repeated small ineffective starts. That is otherwise called start hesitation or ignition failure. They are not glued to the floor. They lift their feet, but they are not lifting it sufficient. They make only a small distance lift, and instead of putting the feet forward, they do a static march. So that is called ignition failure or start hesitation. In the same place, they do repeated oscillatory movement and then they move forward. So it is start hesitation or ignition failure seen in extrapyramidal disorders. So apparently, our patient's problem was not looking like an apraxia. It was not looking like a freezing. It looked like a start hesitation. Or ignition failure. Look like that from whatever we got. And once he starts walking, does he have any pulsion? When he starts walking, you said that he is having multiple small steps. Then when he walks forward, what happens to his gait? Is it faster or is it with a pulsion?
It becomes faster.
So those things, what happens to his posture when he's walking forward? Is the stepping taking place normally, or stepping is ineffective, not clearing the foot completely, and he stoop forwards, and is there a pulsion? So all those things you can tell that will complete that it is a extra-abdominal gait disorder. And gait disorders, for your purpose, you classify them in the lower level, middle level, and upper level. You know that, no? It is called NUT, N-U-T-T, NUT. Not at all classification. So gait is classified as lower level gait disorder, middle level gait disorder, and upper level gait disorder. So lower level gait disorder is, it can be muscle nerve, or it can be combination of muscles and nerve, neuromyopathies, myopathies, anterior console disease. They are all lower level gait disorder. Whereas middle level gait disorder will be spinal cord, cerebellum, basal ganglia. They are all middle level gait disorders. Whereas higher level gait disorders, generally, when you examine, you may not find much. For example, apraxia. When he starts, he is so difficult. Patient feels, I cannot lift at all. My feet is glued. But once he starts walking, he is very comfortable. So unless you know that this is an apraxia, you might think what this man was doing. So very little findings, but really difficult. Or it may be multifactorial. Patient may have cautious gait of elderly. So higher level gait disorder is apraxic gait, some element of freezing gait, or you may have festinating gait, or you may have a cautious gait which is multifactorial. Senior people have poor vision, poor audition, poor proprioception, poor joints. When you examine, you grossly feel okay, he's only having some problems related to his age, his joint is little osteoarthritis is there, he's having slight decrease in the vibration, but the patient will be very much frightened. So that is called as a cautious gait, fear of falling. He is afraid of falling, so he's very cautious, out of proportion to whatever deficit he's having. So higher level gait disorder is deficits demonstrable or very less, but patient's gait is abnormal. That is higher level. Cautious gait due to multifactorial, apraxia, and the freezing gaits. They are all considered as higher level gait disorder. So in this patient, it looks apparently like a middle level. So middle level gait disorder because he is having a festinating gait with a stooped posture and a pulsion effect. So it is probably a middle level gait disorder. We can call it like that. And definitely belonging to the extrapyramidal system, because what he has is a ignition failure, which is not seen in cerebellar disease, which is not a feature of pyramidal disease. Middle level involves pyramidal, cerebellar, extrapyramidal. Cerebellar will have a swaying or reeling gait, whereas pyramidal will have a dragging, whereas extrapyramidal has got the ignition failure. So it belongs to middle level gait disorder belonging to the extrapyramidal system. Third, you told me that he is having falls.
Yes.
Third symptom is falls, no?
Falls.
Or anything else?
Change in handwriting that the patient.
Oh, okay. So what all the changes you can get in handwriting normally? That is called graphology.
Yes.
Study of handwriting in analysis of neurological illness is called graphology. You see, it can be due to language area problem, it can be due to motor, cerebellar, extrapyramidal. You see, you can have a writer's cramp where the patient has got various types of task-specific dystonia resulting in altered handwriting, and you can have a cerebellar where you get macrographia, or you can have a extrapyramidal bradykinesia manifesting as progressive micrographia. So when you start the letter, your letter is big. As you keep on writing, the letter becomes smaller and smaller. It is a manifestation of bradykinesia. So progressive smallness is extrapyramidal bradykinesia. Small, progressive big is cerebellar.
Yes, ma'am.
Whereas cramped and distorted is writer's cramp. And tremors, what you generally do is something called Archimedes circle. I think you all know. You tell the patient to draw a spiral. That is called Archimedes circle. We tell them to draw a spiral. In that spiral, you can see what happens to the spiral and what happens to the patient's body part. Abnormal twisting, abnormal posturing, abduction of the limb, that will be writer's cramp. Multiple dots in the spiral is chorea. And tremor will show the tremor. The spiral becomes bigger and bigger in cerebellar. It becomes smaller and smaller in bradykinesia. Then you can have micrographia and macrographia if the person has got micropsia and macropsia. Some letters he sees small, some letters he sees big. Accordingly, he will amplify or small, reduce the size of the letter. So if the person has a mixed letter, it will be due to both the common metamorphopsia. Patient has got micropsia and macropsia. If the patient has got an organic micropsia, again you will get a macrographia. Because each one of us has got a handwriting size. Unless you are having only one bit of paper and in that class you want to finish, you write small pathological. It's not your way. No? But if you have macropsia, you write very small because your brain is seeing it as big. Person is having macropsia, so everything seen is big. So the brain will tell this is your size of your handwriting. But it is really not so. It's an amplified perception. So patient with organic macropsia will have micrographia, and organic micropsia will have macrographia. And that will be uniform. It will not be progressive smallness. Whereas in extrapyramidal disease, the starting will be bigger. You keep on doing it, becomes smaller and smaller. Like you demonstrate bradykinesia, like this, no? Amplitude and frequency become slower and slower as you proceed. Similarly, the spiral, Archimedes spiral becomes smaller, closing in inside. Or you write one page, first letter will be bigger, subsequent letter will be smaller, smaller, smaller. Progressive decrease in the size of the letter is very typical of bradykinesia. So he said it is become small. If it has become small, you should tell what about his vision. Is there any visual symptoms? Because you can have conditions like DLBD, diffuse Lewy body disease, where you can have extrapyramidal features, you can have occipital features. So does he have anything like that? We don't know. So you have to tell he has other aspects are all right. His letter is not uniformly small. It is progressively small. As he keeps writing one page, the first line is much bigger and the last line is much smaller. So progressive smallness of the handwriting is very typical of extrapyramidal. You have to see at least half a page and you see compare the first letter with the last letter. The size will indicate bradykinesia. So that is the handwriting. Next is the fall. And fall, how does he fall? You have to tell. He falls forward, backward, multi-directional, sidewards. How is he falling?
He had only once a fall, ma'am. He fell forward, ma'am. He slipped. The history was he slipped and he fell forward.
Forward, okay.
Only so once fall and then he had a fracture.
Usually, Parkinsonian patients, idiopathic Parkinsonism falls happen only when they do turning or multitasking. Whereas Parkinson plus syndrome patients, they have repeated falls. Patients with PSP, DLBD, MSA, they have repeated falls. But idiopathic Parkinson patients, they fall during multitasking. You are walking, somebody is calling from behind, you are quickly turning carelessly or not, your balance failure. It is due to balance failure. So mostly they fall during multitasking. You are doing something and somebody is distracting, or you are trying to do something which is out of the way, a novel target avoidance, some foreign body coming or trying to avoid, like that you might fall. Or you, because of the pulsion, but generally they don't fall. They know that they have propulsion and retropulsion. So they may appear as if they are going to fall forward or they are going to fall backwards. But they know to balance. They go and touch some wall or something like that, and they balance themselves in an odd posture. Usual faults are during multitasking. You are walking and you are distracted, or you are walking and you are turning. So during multitasking, there is a tendency to fall in idiopathic Parkinsonism, unlike what you get in Parkinson plus syndromes. Whereas pulsion will look as if he is going to fall, but they will go and stand in an odd posture. They move very fast, and they go and stand in that posture. So propulsion and retropulsion will look as if they are going to fall forward or backward, but they learn to balance and they stand. So you had only one fall. You said it was tripping.
Yes.
So apparently it was something like a multitasking. He was walking in a level ground, probably some foreign body struck him, and it looked like a distraction to his gait, and he fell down, probably.
Yes.
Whereas classical falls in the fifth circuit, substantia nigra to pedunculapontine complex, there will be multi-directional sudden falls with the trauma, retained consciousness. They fall in multiple directions and correct themselves. That is the thing.
Yes.
So now, and you clearly said that he does not have any RBD, no REM sleep behavioral disorders are not seen, and he has no autonomic features, he has no bladder, he has no cognitive features, he has no eye signs.
No eye signs.
Generally, they will tell that their acuity is failing, but it is not correctable with glasses, it is not due to cataract. You see, because you have slow vertical down movement, slow up movement, or slow horizontal movement. We classically say down gaze palsy is PSP, but up gaze can be involved, but classically it is the down gaze which is PSP, and you get horizontal eye movements become slow in idiopathic PD, and you get up gaze in normal aging and sometimes in MSA. So because the vertical movements are impaired, patient is unable to do the synthesis of saccades and pursuit and bring the eye to the target of interest. Because of that, his vision becomes blurred. So they will go to ophthalmologist. Ophthalmologist will check the acuity and give him a glass. They will tell that there is no cataract, but the vision is not improving. So that is eye movement. So patient does not have autonomic features, he does not have any cognitive features, and he does not have any visual symptoms apparently. So probably the eye movements are not involved. So it is an asymmetrical upper body PD. We started as tremor and then went on to some gait disorder, and some falls happened, or minimal, only one fall during distraction happened. So it is definitely the indirect pathway with some direct pathway features. The direct pathway features is the bradykinesia, which is manifest in your patient as slowness. So you can say that towards the end of the presentation, it is not just the direct pathway, the indirect pathway is also involved. Because patient has got both hyperkinetic and hypokinetic. He is having excessive movement in the form of tremor, and he has got reduced movement in the form of slowness and bradykinesia and micrography. So like that. So it is both the direct and indirect pathway pathology. And because other parts of the neuroaxis is not involved, it is looking like an idiopathic Parkinsonism. So you have got primary Parkinsonism, secondary Parkinsonism, and Parkinson plus syndrome. Secondary Parkinsonism is what you said, MPTP, people who have been using addictive substances, or they have been using drugs, or they have suffered head injury, or encephalitis, Japanese encephalitis. You know, it is well known to produce extrapyramidal involvement. So secondary to trauma, multiple strokes, or drugs, or due to head injury, if the person develops an extrapyramidal syndrome, it is called secondary. Why it is secondary? Because they are again not going to be progressive. That is why they are put as a second group. It is involving parts of the brain other than the extrapyramidal system, but it is not going to be progressive. It will be arrested. Post-encephalitic, it will improve or arrest. So that is secondary. Whereas tertiary Parkinsonism is extrapyramidal plus other parts of the neuroaxis, and they are progressive. They are the tertiary. Under tertiary, you have got a PSP, MSA, CBD, you have got DLBD, Parkinsonism dementia complex, Lewy body disease. All these are coming under tertiary Parkinsonism, because other parts of the neuraxis is not involved, no exposure to drugs, toxins, no head injury, no encephalitis. So probably, and asymmetrical upper body. So probably it is idiopathic Parkinsonism. Correct. So would you like to tell me the James Parkinson's definition of Parkinsonism? Very beautifully
he did. Shaking palsy.
Yes. Involuntary tremulous movements, his own words. Involuntary tremulous movements in parts not in action. So he described resting tremor as involuntary tremulous motion in parts not in action. No? With the propensity of the patient to move from walking to running. That is pulsion. So walking is difficult, running is easy. So propensity of the patient to move from walking to running and intellect remaining unaltered. So he also knew it is idiopathic PD. It does not involve cognition. So involuntary tremulous movement in parts not in action with a propensity to shift from walking to running and mind and intellect remaining unaltered. That is the definition by James Parkinson. Whereas Charaga's definition also you should know, because we have to tell about our people who lived in the BC, long before James Parkinson. No? They classified it as Pada Kamba, Karo Kamba, Siro Kamba, Sarvanga Kamba. You see, very beautiful. No? You should know there was no MRI. When I was recently reading Bhagavatam, I was so surprised. They are telling the travail of the fetus in the womb from the one cell stage, how it becomes so many cells, when it starts excreting urine, when it starts, how beautiful. There's no ultrasound, nothing. No? It's a chapter on travail of the embryo in Bhagavatam. So wonderful. So it is our responsibility to understand our ancestors who were far ahead of us with the equipment that is their own brain, nothing else. They did not irradiate the environment with so many machines, and they irradiated the environment with their brain only. So you should be very proud of them. So he called it as Karo Kamba, Siro Kamba, Pada Kamba, Sarvanga Kamba. Kamba Vada is the name for Parkinsonism. Sarvanga Kamba means bilateral, symmetrical, whole body gets together involved. That's the worst. That is the tertiary Parkinsonism. Sarvangam. It is not asymmetrical. Whereas Pada Kamba is vascular. I told lower body, Binswanger's disease. So Pada Kamba is good according to them. And Siro Kamba and Karo Kamba. So simplest one is Siro Kamba. Head tremor, essential senile tremors. That is what they call it as a Siro Kamba. So Siro Kamba is the best Kamba you can have. Then Karo Kamba is the next. Pada Kamba is the third. Sarvanga Kamba is a PSP plus a PSP, all those things. No? That is Charaga's classification. No? So first you have to call them as the fathers of neurology in the world, because that is anonymity and knowledge is free. That is Indian. You remain anonymous and you want knowledge to spread. That is truly Indian. And it is our duty and responsibility to bring back that glory to our country. It's our responsibility. If the son of this soil does not recognize, which soil will recognize? Nobody will. And our traditional culture will be buried gloriously. That should not happen. It is in your hands only. So you should remember. And there is another story also for a doctor. No? My George Coates, you heard, no? George Coates is the person who tried to extract L-DOPA from Naikurne. So this Naikurne was used in Ayurveda for treatment of Kambavada. Then when the British were ruling this country, I think it is Robert Clive, they found that one drug is working. At that time, whole world has no drug. And if you have patented Naikurne, the whole world would have been purchased with that Naikurne. It is ours. It was taken from our country. No? So our ancient, because knowledge is free. Loga samasta sigino bhavantu. Let the whole world live peacefully. What does it matter? Robert Clive is asking, they gave the plant. And he took it to George Coetzee. And he told him, this is working. So try to find out what is the thing which is divide and rule is their system. No? So they will divide the leaf, the root, the stem, everything divide and rule only. So they divided and tried to find out alkaloid. At that time, George Coetzee started a voluntary recruitment center for patients with Parkinsonism for a trial. Then what happened? Those times, stand erect, walk erect, to swing your hand cautiously, stand. So that was a journalist who was very angry. You have recruited me, you are not so far given me anything. You are forcing me to walk. When I cannot walk only, I am here. And he will hit to that Dr. George Coetzee. His retina became detached. That time there is no treatment for retinal detachment. So he became blind in one eye. He did not give a complaint against the patient. But even before he could, subsequently somebody else extracted the L-DOPA, because Ayurvedam believes together, agonist, antagonist is there together. So side effects will be less if you use as a natural resource, because side effects will be antagonized, effect will be amplified. That is Ayurvedic principle. Whereas you take only the active alkaloids, so side effects come, freezing, yo-yoing, random oscillations, all those things come when the alkaloid is extracted and given in the pure form. George Coetzee could not do it in his lifetime because he got bronchogenic carcinoma. That time he will call this journalist and tell, you made me blind in one eye. Still I did not do anything, even though you know that you were a voluntary recruit in your research project. Now you should write about me when I am dead, that this doctor tolerated me. So altruism is our job, like army people. You should not sell your degrees. We should not make ourselves cheap. People among us sell themselves to medical companies, pharmaceutical. Once you start enjoying all those things, it is very, very difficult to come down. I have seen my own students in front of my eyes, very sad. Why you will sell your degree? It's a very hard earned degree. It is not for sale. It is for mankind. You should remember that. You don't have a purchasable or a sellable degree. You have something which is absolutely divine, and you will use it for mankind. That you should know. So what happened? So this journalist is coming out of the doctor's room, knowing that the doctor is going to die. Then he understood how wrong I was. I thought that doctor did not give me anything. Doctor had given me his shoulders. Now that shoulder is not there. He could not walk at all. And his last line is, he became bend and bend and bend, because he knew that the doctor is going to die. So even when you are not giving them anything, we can give them our shoulders. And that's a great privilege. Nobody else can do it to a stranger. You love strangers. You give them your shoulders, consciously or unconsciously, unselfishly. So that is why even Charaka Samhita is saying, doctor can go to the temple without bathing. All those ceremonies are for ordinary mortals. You can go without bathing. It is mentioned. Because you are a special person. You are already in the temple. When you are serving your patients, you are already in the temple. So what is the need for you to bath? Not needed. So that is the sanctity of our profession. And the journalist has written like that. When he came out of George Coetzee's room, he could not walk at all. Then suddenly realized the shoulders were there for him. It is no more there. So that is the divinity of our profession. Understood? So nice. Thank you. So from the history, we think there is a direct pathway and indirect pathway is involved. Okay. There is no other part of the neuroaxis involved. There is no other secondary cause like trauma, infarcts, or drugs. Nothing is there. So probably it is idiopathic Parkinsonism. Agreed. On examination, you tell me.
Yes, ma'am. Elderly male, conscious, cooperative, lying supine on the bed, well known time, place, and person. Mild pallor was present, no cyanosis, clubbing, lymphadenopathy, or edema. Hemodynamically stable. On the nervous system examination, higher mental functions, patient was conscious, cooperative, well known time, place, and person. Was a right-handed person. Attention was normal. Memory was normal. Language, spontaneous speech, comprehension, naming, reading, repetition was normal. Writing, micrography was present. Memory was intact. This was the handwriting.
What has he written? He drew some duck. Huh? What is that? This is Kannada.
His name in Kannada.
Oh, sorry. I cannot read Kannada.
Yes,
I think the letters have become smaller, but they look like
compared
a mix.
To before, the patient attender said they become
some of the letters are small, but some of them are big. Is it the way those letters look like?
Yes,
maybe the configuration of the letter itself is big.
Yes, ma'am.
Otherwise, if you tell him to draw the same A,
okay,
then you'll see becoming smaller and smaller.
Okay.
Depending on the way the letters are written. Some of them are very small. It is not the classical progressive micrography. You should at least sample 3-4 lines.
3-4 lines, okay.
Then only you will know.
Yes. Cranial, there's no cranial nerve involvement. Actually, no diplopia.
Specifically, you should tell about eye movements.
Eye movements normal. Pupillary reflexes are present. Extraocular movements are
in
normal.
idiopathic PD also, you can get a cogwheel pursuit sometimes. No?
Okay.
That is a circuit can be, pursuit can be broken. Multiple like this, cogwheel.
One doubt, when you are mentioning third, fourth, sixth nerve palsy, there only we should mention saccades and pursuits, or we should mention separately?
You see, you can specifically mention about eye movements because third, fourth cranial nerves means it is a lower motor neuron.
Okay.
It is not saccade or pursuit. When you go after your cranial nerves, you can specifically mention after the higher mental functions. You can mention about eye movements specifically in cases like this.
Okay. Other cranial nerves were normal. Motor system, there was no obvious wasting that was seen. Tone, there was cogwheel rigidity in bilateral upper limb, both left and right side.
What is Nokia Frohman's monover? Heard of Nokia Frohman's monover?
I'm not sure of the name, but is it that we try to distract the patient, wherein the rigidity worsens while distracting the patient?
So Nokia Frohman's maneuver is, you see, you grade it by how many limbs are involved, that helps us to grade the stage of the disease. One limb is symptomatic, the other limb you are not finding any rigidity at rest. Then you tell the patient, if you are checking for rigidity in the left wrist, you can tell the patient to move the right hand. The right hand is moved up and down, then look for rigidity in the left, or vice versa. Then the rigidity which is not obvious otherwise becomes unmasked. That's one method to unmask the rigidity. Like we do the Chandra 6 maneuver to release reflexes. Rigidity is released by moving the opposite limb in a limb where it is not obvious. That is called Nokia Frohman's maneuver. When do you use the term cogwheel? It is rigidity plus tremor.
Tremors. Power, there was no loss of power in both the upper limb and lower limb. The power was normal throughout. Superficial reflexes, knee and ankle, I felt it was 3, ma'am. But plantars were still flexor. Is that
the reflexes can be exaggerated, yes. In Parkinsonism, you can have exaggerated reflex, normal reflex, or impaired reflex. All can happen. That is something called alpha gamma coactivation. Someday I will take one theory session on tone.
Yes, ma'am.
Then I will teach you how it happens. In cerebellar disease, you get hypotonia with retained reflex. In extrapyramidal, you get hypertonia, rigidity, with the absent reflex, normal reflex, or exaggerated reflex, depending on the alpha gamma coactivation principle in favor of what. So that way you can have a stretch reflex alterations in extrapyramidal disease. It can be any one. It may be normal, it can be absent, or it can be exaggerated. All can happen.
Coordination.
That does not indicate corticospinal tract.
Okay. I didn't count the number of, I could not, I was not sure how to count for 1 whole minute, which movement to take, because it was completely pill rolling. So
okay, pill rolling movement itself, when you say it's a low frequency movement.
Low frequency. Worsening movement on there was resting pill rolling tremors, which worsened on movements of the opposite limb or while talking or while eliciting history, and it disappeared on performing any of the actions. And glabellar tap was present, persistent.
Okay.
Sensory system was normal. Cerebellar system was normal. Gait were not able to assess because he had a fracture and he was immobilized.
Okay.
Other systems were normal, so I would think the neurodeficient.
So after examination, we did not get any extra points other than the fracture. No?
Yes.
Okay.
There's
So
a
it's
video.
A progressive disease. Okay, sure.
I'll just pause the screen.
Release reflexes in Parkinson's. In Parkinsonism, release reflex, you mean what? Primitive reflexes you're asking? So release reflexes, I told about Chandra 6 maneuver, releasing a subclinical deep tendon joints. Otherwise, release reflexes indicate frontal lobe involvement. So you do not get in the idiopathic Parkinsonism, the palmar-mental or snout or sucking, rooting reflexes do not happen. But towards the end stage, as you know, most of the subcortical circuits go through the frontal lobe. Corticostriatopallidothalamus, corticostriatopallidosubthalamus. So most of these circuits are going through the frontal cortex. So when the Parkinson's disease becomes end stage disease, the frontal lobe features can come. Even in idiopathic Parkinsonism, towards the end, executive functions, mental slowing. So all these things happen. Mental slowing and executive function impairment happens. So at that stage, when the frontals, because of the end stage of the disease, frontal lobe volume loss happening, then you can get release reflex. Otherwise, you get release reflexes in FTD PD. So frontotemporal dementia with Parkinsonism. Or you get Parkinsonism dementia complex. Or you get it in vascular Parkinsonism. Or you get FTD ALS. So you get all those reflexes in a person with Parkinsonism only in the early stage. If you get it, indicates it is not idiopathic Parkinson. It indicates the frontal lobe is also getting involved. So it is a Parkinson plus syndrome. Okay, okay, ma'am. So you show the video. Not coming.
2 minutes, some issue.
Yes, sure. No problem. At this point, we can discuss how are you going to confirm your diagnosis clinically or in the laboratory. As you know, the routine MRI may not show anything. Clinically, you can, when nothing else is there, you think it is idiopathic PD only, and you can give a dopamine trial. Very good response to full dose of L-DOPA. L-DOPA trial gives a very good response, and you do not have any autonomic dysfunction, everything else on complete examination. Then you that is clinical. One is clinically no cognitive dysfunction, no other part of neuraxis involvement, and L-DOPA trial showing a very good response to levodopa therapy, that is favoring idiopathic Parkinsonism. And routine MRI will not show anything. Supposing you say PSP, you have the hummingbird sign, or you have got the morning glory sign, or pregnant pond sign, so many things. Or if you have MSA, you have got hot cross bund sign, or you have got a striatal hypertension, none of these will be there. So apparently normal imaging, unless you do special DOPA imaging, you may not get anything abnormal in idiopathic Parkinsonism. So that's the laboratory method. Then of course you can grade the severity using the UPDR, Unified Parkinson's Disease Rating Scale, can be used to know the severity. Then you should know there is something called data tops. Early, as you know that L-DOPA is the most effective drug. You can give it to try the confirm clinically, but it is better to sustain the patient unless the patient has any functional disability. You can tell him to wait. because you do not have much disease modifying treatment. You have only symptom modifying treatment. So initially, DOPA, either you just do physiotherapy, just some periarthritis like slowing, nothing, not interfering with this activity, no need to start treatment. And once mild disability is coming, there is a thing called data TOPS, that is DOPA agonist, tocopherol, and amantadine therapy of Parkinson's. Data TOPS, it is called DOPA agonist, tocopherol, amantadine. Tocopherol is antioxidant, DOPA agonist, and amantadine can be used. And DOPA can be reserved for later part because DOPA works very well, but it works for only some 5 to 6 years. After that, patient develops DOPA-induced complications, yo-yoing, random oscillations, dyskinesias. So better to reserve DOPA as long as possible. Here, what you are finding that your patient's hand is like flexed at the wrist, flexed at the metacarpophalangeal joint, and flexed at the interphalangeal joint, looking partly like a striatal hand. And you have got the tremor. Of course, yes, I think he's only 65. You should force him to get operated for the hip. 65 is not old age, no.
Yes, ma'am.
You should coax them because they don't know. Hip joint surgery is not very difficult. So it's a striatal hand. It looks like a striatal hand from the posture, and you have got the pill rolling tremor. But if you have taken the side view, it might have been much better appreciated. So this hand I will call as a striatal hand with a pill rolling tremor. Can we differentiate drug? Yes, drug-induced Parkinsonism. One, it is short duration, rapid progression, oculogeric spasm, drooling, akinete or rigid dominant. So they are never asymmetrical. They are symmetrical, akinete or rigid dominant with or without drooling. So they will be symmetrical, short duration, rapid progression, and they are akinete or rigid and not tremor dominant. Any other video is there, ma'am? Any other question? So this is a striatal hand with a pill rolling tremor. Agreed. But I think you should coax them. Poor people, no? You should tell them to get operated. Why he should lie down like that, get bedsore and die? You should not permit that.
Yes,
sometimes you can decide for your patient if your intentions are pure. Especially, I think that part of India, people are not that hostile like Kerala. Kerala people are fighters. So you have to be very careful. You tell them something with good intention, they will think of a wrong reason. So that is not like that in Karnataka.
Yes.
Innocent people. So you have to coax them, not kill that person like that.
Yes, ma'am.
Any other video is there?
I was not able to take. I'll just see, ma'am. 1 minute, yes, ma'am. One question, ma'am. Cause of autonomic dysfunction in Parkinson's disease.
In idiopathic Parkinsonism, you do not have autonomic dysfunction. You get autonomic, if you get it, it is not idiopathic Parkinson's. You may get bladder. That bladder is not actually due to autonomic involvement. It is due to Barrington center. The Barrington center is in the basal ganglia and which is having a higher threshold. So you get frequency, but you will not have any pre-voiding, voiding, post-voiding changes will not be there, but you have frequent emptying. Otherwise, you do not get any autonomic features in idiopathic PD. If you get autonomic features, it is a Parkinson plus syndrome. Progressive autonomic failure, which can be purely autonomic plus cerebellar, autonomic plus Parkinson's. That is MSAACP. You see? So those, if you get autonomic features, it goes into Parkinson plus syndrome. It is not idiopathic. There is a multi-axial degeneration. Olden days we called Scheidegger syndrome, Riley-Day syndrome, and those things. Any other question?
What would be when should we suspect Parkinson plus syndrome?
See, one thing clinically, second, pharmacologically, third laboratory. Clinically, you think a person has symmetrical with some evidence of other parts of the neuraxis. It may not start with tremor, it doesn't start in the upper limb. PSP patients start with fall. MSA patients, dizziness, giddiness, imbalance, no? Bladder. Initially, they may land with a urologist. No? So that kind of non-extrapyramidal onset or frequent faults like onset clinically and not asymmetrical. They are fairly symmetrical. Significant involvement of other parts of the neuraxis. So that gives you clinical clue. The second, pharmacotherapy, levodopa trial. It will show very poor response to levodopa and dopa agonist will not work at all. So you give a levodopa trial, the response is very poor, unlike the idiopathic PD, and dopa agonists do not help. So that is a pharmacological level. Clinical level, other parts of the neuraxis involvement and onset not as asymmetrical upper body tremor. Onset is in the other parts of the neuraxis, not in the classical way in which your patient started. So then levodopa responsiveness is poor and incomplete. Dopa agonists do not help at all. Then in the laboratory, you, as I told, simple MR itself will show finding. Idiopathic PD does not show. PSP will show the coming bed on the morning glory, pregnant bond signs, vital, hot cross bund sign in MSA, and you get MSAC, and in MSAP you will get striatal hyperintensities. Then when you do the autonomic function test, you find autonomic functions and dopa transporter studies. Unlike the idiopathic Parkinsonism, it is not necessarily in the substantia nigra. So like that you differentiate. It's of prognostic relevance. And I have written one simple method, blink reflex. I have published it in the Neurology India. If you find early that blink reflex, any electrophysiology lab can do. If you find abnormality in the blink reflex early, that might point to a brainstem involvement. So it's a PD plus. Because I am a floor neurologist, I always look for simple clues. So first time I have described the role of blink reflex in early sometimes some cases may be difficult. You are not sure whether it's akinetrorigid Parkinsonism, which can be part of an idiopathic Parkinson's. So trauma dominant is not happening. In that situation, you may have mild difficulty, some situations. Then you do the blink reflex. If blink is abnormal, you can say that it is a PD plus syndrome and your prognosis not going to be good. It's a very simple tool. Anybody can do it. I'm not saying it is 100%, but if it is abnormal, it helps as a pointer. So only a pilot study I did. After that, you have to do it in a larger study, and that is published in Neurology India. You can see that. Blink reflex.
One more question was, can Parkinson's disease patients have hallucinations? And if and how to localize hallucination in Parkinson's disease?
You see, Parkinson's, idiopathic Parkinson patients get hallucinations due to drugs usually. You see, both dopamine and dopa agonists, anticholinergic drugs. When you get trihexyphenidat, no? So it is usually drug related. Idiopathic Parkinsonism patients do not get hallucination as a primary feature. When they get hallucination, it is usually drug induced. So especially the anticholinergic drugs. And even syndopa can produce, but it is more common with anticholinergic drugs. So then you have to optimize the drugs. You can even withdraw them. So that is in idiopathic PD. But the hallucinations, formed visual hallucinations, are typical feature of diffuse Lewy body disease. So very vivid, formed human beings, children running over them, sitting on their hand, laps, you know. That is typical of diffuse Lewy body disease. There the hallucination is early. So hallucination can be the first feature, then they develop some cognitive dysfunction and PD features. So early hallucination before the drugs have been initiated, cognitive dysfunction and PD features coming later, points a part of the degenerative disease which involves the occipital lobe. Most of the cortical dementias do not involve the occipital lobe. Frontotemporal, frontal lobe and temporal lobe. AD, parietal lobe and temporal lobe. Occipital lobe is resistant to the classical degenerative diseases of the cortex. So one which starts in the occipital lobe is DLBD. So that can start with the formed visual hallucinations. Otherwise, in Parkinsonism, it is drug related. Pedunculopontine. What is that question you didn't, doctor? What is the one question? Pedunculopontine. Half only I read.
So in PSP, pedunculopontine nucleus is involved. So
Yes.
can they get pedunculopontine hallucinosis?
No, that is not pedunculopontine hallucination. You have got a peduncular hallucination. That is different. Pedunculopontine nucleus is in the pons, whereas peduncular hallucination is in the midbrain. It is in the cerebral peduncle. So peduncular hallucinations do not come from the pedunculopontine nucleus. It comes from the cerebral peduncle. That is why it is not called hallucination. It is called hallucinosis. Because that is the only hallucination, if you want to take it as an MCQ, that is the only hallucination attributed to a white matter. It's a tract. It's not the gray matter. So, and patient is aware. So, peduncular hallucinations or hallucinosis of Lermit. It is called peduncular hallucinosis of Lermit because it is coming from the white matter. Patient will know. Other DLBD and all, they say, you see, my child is running over my body. You feed him, you give him chocolate, they will tell. If you disagree, they'll be angry. Whereas peduncular hallucinosis, patient will know it is not for others. Only I am seeing, but I don't know why. It is animals and colors running around, vivid. But I know it is not there for you. I am perceiving. So patient consciously knows that it is not true. Others are not seeing. That is why it is called hallucinosis. It comes from the cerebral peduncle. And it is the unique features of only white matter. Patient's cognitive understanding that it is not real is there. So you call it as hallucination, hallucinosis. And here it will contain animals and colors which are vividly motile. So that is typically seen in top of the basilar syndrome, otherwise called Kaplan syndrome. When the top of the basilar artery branches are getting occluded, you get peduncular hallucinosis. So another situation where you get peduncular hallucination is use of LSD, lysergic acid diethylamide, the addictive drugs. When you use addictive drugs, you can get a peduncular hallucinosis. Otherwise, it is cerebral peduncle. It is not pedunculopontine nuclear complex. Any other question, ma'am?
Next question is how to elicit blink reflex is one person they've asked.
It's an electrophysiological reflex. No? Normally, he elicited the blink reflex. No? He told that it is not adopting. Blink reflex is an electrophysiological procedure. R1, R2, those things are more into theory. So you can read electrophysiology book. It's a procedure. It's not at the bedside. It is in the EMG laboratory. You put electrodes and stimulate and record the complexes. One which comes from the orbicularis oculi and the second one which goes to the brainstem and comes both to the ipsilateral eye and the contralateral eye. First is the direct blink which comes from the ipsilateral orbicularis oculi. Second complex goes through the brainstem and comes both ipsilaterally and contralaterally. So that the blink reflex second component which goes to the brainstem, if it is delayed, even though clinically brainstem features are not there, it indicates that apart from the extrapyramidal system, rest of the neuroaxis is involved. So abnormal blink reflex indicates the pathology is not purely confined to the basal ganglia, it is involving the brainstem. Like that. Where to localize that symptom? Which symptom?
Why do Parkinson's disease patients bend forward? And that bending forward, where to localize? That's the question.
See, bending forward is a Parkinsonism is a disease of posture and equilibrium. So your posture becomes abnormal. So a posture maintenance system, it is one of the posture maintenance system. So basal ganglia disease necessarily produces impaired posture maintenance. Because of the impaired posture maintenance, your center of gravity is not made to go through the spine exactly and fall in between both feet. Normal posture maintenance, ability to align body parts in balance with the gravitational pull, that is posture. Ability of the individual to maintain body parts in agreement with the gravitational pull. That means the center of gravity should fall in between both feet and it go through the spine. That is normal posture maintenance. Normal posture maintenance, the most important structure is basal ganglia. It is supported by cerebellum, proprioception and vision. So when the basal ganglia is gone, the posture maintenance system, the mechanism of posture maintenance, that is putting the center of gravity through the spine of the person in between both feet so that you are able to maintain your erect posture in balance with the gravitational pull. That fails. Primarily, that is a function of the basal ganglia. So when it fails, you are unable to maintain the posture. So because you are not able to maintain the posture, you bend forward. And when you bend forward, what happens? Your center of gravity is not falling exactly in between both feet because it goes through the spine and it falls little forward. So to keep the balance, to keep the posture, you have the propulsion. You run to capture the center of gravity in between the feet, but it is not happening because the posture control mechanism is erratic. That is also huge topic like maintenance of tone. Maintenance of posture is involving multiple parts of the neuroaxis. It's a theory topic. These are my favorite topics only. But sometimes in between, when I am relatively free, we can have some topics in this area. But what is that? Meyerson sign is failure of adaptation of the blink reflex is called Meyerson sign. So what question you are asking, ma'am? What is that question you asked?
Yes, they asked to tell about this sign.
No, normally, the blink reflex is for what? Blink reflex is for protecting your eye against a foreign body which is trying to injure your most vital organ. So that doesn't keep on happening many times. So when you tap many times, body will learn, the cognition will learn that it is no more a danger, it is an elicited response. So the cognitive circuits adopt. They do not want, they know that, they learn there is no danger coming to the eye, it is an elicited thing. So it will stop blinking. But when that when there is a degenerative process, the cortical and the subcortical communication becomes less. That learning is not taking place. So it keeps on blinking. Any other question? That's all.
That one more video I got. That both the hands are there.
Yes. But I think you should coax them to operate.
Get operated.
They don't know. Here I think that he has also secondary changes in the joints. Okay. It looks like the joints are swollen. Okay. Apart from the classical striatal hand, the joints look like you can have something like a periarthritis shoulder, back pain, and a freezing of joints secondary to bradykinesia. So probably he looks like the joints are swollen. Okay. I'll call this as a striatal hand with the secondary joint changes.
I think no more questions, sir.
Okay, thank you.
Thank you so much, ma'am.
Very well, nice.
Thank you for your blessings and your guidance always, ma'am. We seek your blessings always.
No, ma, because as I tell, no, big people can do big activities. I can only do this to my country. So you are giving
this is
me an opportunity.
very big for us, ma'am. but through this, lot of students are learning.
So
Very
thank
useful
you.
to all of us. Thank you so much.
Thank you so much. If you feel so, I am so grateful to God that you have given me this opportunity. Thank you so much.
Thank you so much.
Thank you. Okay, we'll close. Class.